Hi, I'm Eric Prystowsky, and welcome to another segment of EP on EP. It's a delight to have with me Doug Packer, and I want to say right up front that I'm going to ask you to review a previous one that Doug and I did on the CABANA trial. That's what we're going to talk about today, but we're going to talk about the results of it. So there is a wonderful video that we've done previously that goes through the whole trial. Doug, thanks for being back here with me to discuss finally the results. And Dr. Packer is officially the Charles Nassif Professor of Cardiology at the Mayo Clinic, but he's the man about town, and he's the lead investigator for CABANA, and it's a wonderful study. And Doug, give us the main results, and then we'll sort of talk about it.
Eric, thank you for letting me come here. I enjoyed our past interview, and now I have something to show for it.
Right.
If you looked at what we talked about before, we talked about a trial where we're going to compare ablation versus drug therapy. The finished trial now is 2,204 patients enrolled. Half of them randomized to drug therapy, half of them randomized to ablative therapy. And we went all the way through the trial and had data on about 1,000 patients on each side. There were some crossovers. There were 301 crossovers from drug to ablation, and then there were 102 patients who were supposed to have been ablated that never got ablated.
I remember that was actually a peculiar part of this trial. Really does kind of goof up your intention to treat stuff.
Anytime you have crossovers or where trial participants don't remain in their original point of randomization, it can change intention to treat. And it's one of the little known problems with intention to treat, where you can have a fair amount of bias interjected if you don't keep that in mind.
Right.
So with the trial, the first thing we looked at was this thing there.
Part of the problem of, would you have 1,000 interviews yesterday after the trial? You have no voice left.
Yesterday I had 1,001 interviews.
Well, thank you for hanging in here and doing 1,002. I appreciate it.
It wouldn't be with just anyone, Eric.
Sweet. Go ahead.
So the first thing you look at in any trial is intention to treat. And what that means is a person gets randomized to one therapy or the other. They stay in it the entire trial, and then you make comparisons. And the comparisons we made were primary endpoint: death, serious stroke, serious bleeding, heart failure, cardiac arrest.
Okay.
The second endpoint, or the first secondary endpoint, was total mortality. The third was total mortality and cardiovascular hospitalization. So the thing that we found in the primary by intention to treat is there was very little difference between the two forms of therapy.
Okay.
And that's with the crossovers.
That's with basically 400 crossovers.
400
right?
crossovers. Yeah, and you know, you could say, well, you keep the trial going longer and get 400 more patients in it, which just is not feasible.
Okay.
In the group of patients who we were watching mortality, those patients showed similar findings. It's about a 17%, 15% reduction in total mortality, but it's not significant.
Okay.
But in intention to treat, if you look at the patients who had total mortality and cardiovascular hospitalization, there's a significant difference where the WID went to ablation.
Okay.
17% reduction in that endpoint.
Okay.
More importantly, there's a 47% reduction in recurrent atrial fibrillation. And I don't know how you practice, but when patients come to see me, that may well be the very most important issue that they have, the most important issue that they raise. Well, given the potential biases of an intention to treat, you have to look at how patients actually got treated, or on treatment analysis, or treatment received. In that group, the patients who crossed over from drug therapy to ablation remained with ablation, and we used a time-dependent covariate analysis approach to run the statistics between them and those that stayed in drug therapy. 25
May
to
I stop you 1 second? And then the 100 or so that never got ablation, would they then fit into the non-ablation group when you do that sort of analysis?
they were not considered.
They were not considered, okay.
But the outcome of that was primary endpoint,
Yes.
about a 37% relative risk reduction.
So let me stop you on that because, as you know, I was the discussant after you presented, and I spent a lot of time on basically 5 slides I showed because I knew that there are all these people who are into statistics who just look at a curve, but I'm a clinician, as you, and I want to answer the question for my patient, Dr. P, if I get an ablation, what can I expect? So isn't that the value of an on-treatment sort of analysis?
Well, it is. It's the thing that informs you, given the fact that patients are going to be patients, and some of them are going to stick with what you do when you flip the coin, and some of them won't.
Right.
It's the one that informs you best. So if you look at total mortality, or the primary endpoint, we're talking about a 37 to 40% reduction in relative risk. If you look at the hospitalization or mortality, it's still about a 17% reduction. But our primary endpoints, our secondary endpoints were met given the constraints of that shift in patients.
Right.
And then we did a per person protocol.
I don't know what that is. Would you tell me what that is?
And then we did a per person protocol or analyses. Now the difference between that, Eric, is in intention to treat, everybody stays where they started.
Okay.
In on-treatment analysis, the drug patients stay where they are until they cross over, and when they cross over, then they become part of the ablation group.
Okay.
And then you have to do a time-dependent covariate
Okay.
analysis to make the comparison. For per protocol is for patients who stay with their therapy, and that's it.
That's it. Okay.
So anybody who is taking drugs and wants to cross over, then that patient is censored for
that
the rest
point.
of the trial.
Yeah, okay.
The ablation patients stay the same, so you have pure ablation versus pure
Okay.
drug therapy.
Right.
The difference, Eric, is that those patients those patients are going to be a smaller number.
Right.
But see, even under those circumstances, the differences in the primary endpoint and the secondary endpoint were significant.
Significant. So let's talk take-home points, because there'll be lots of discussion, because there are some people who will look at one curve and say, oh, look at that. I mean, just like when you have all these trials, when some of the DOACs came out, you know, non-inferiority, oh, it didn't do anything. And then patients say, well, Dr. P, if I take this new anticoagulant, what's the deal? I said, well, if you take it, let me tell you what the trial showed. Here's your risks, here's your benefits, you know, because you're going to take it. So let's take this a little different way, because I know people have a chance to read your paper. And again, I just have to tell you, you're an old friend of mine, and we've worked together over the years, but you and I have been talking about CABANA, God knows how long, well over a decade. And I just want to one more time congratulate you. I know how much you put into this, and it's phenomenal effort, so the field owes you a lot. Having said all that, give us a few take-home messages. Forget the curves, forget all that for a moment. What should a clinician take away from this for their patients?
I think I think that a clinician should remember that the intention to treat didn't. I think that the intention to treat was neutral. But that when you're making decisions with patients, you have to be able to tell them what's going to happen if they actually stick with the therapy.
Whichever of them, right? Whether
Yeah.
they stick with drugs or with
And so on-treatment analysis tells you that those patients are going to do well, even in the case of mortality or in the case of mortality and stroke. The big issue there, Eric, is it's a lesser of statistical analyses. But in this case, it's not necessarily more negative. In this case, it's in this case, it's more positive. Patients tend to be less concerned about if they're going to die, as long as they have a good quality of life, as long as they can get out there and do what they want to do, as long as they are happy,
right?
and as long as they have the money to cover healthcare costs.
And to that effect, when I sit down and talk to a patient about ablation versus drugs, my discussion is just that. They want to know, what are the odds that you're going to get me cured? And if I'm not cured, am I going to feel better? What's my quality of life going to be? And what are the risks? So my take-home points as a clinician watching your trial are that at the very least, even with intention to treat, whatever you want to look at, clearly ablation is as good as drugs. I mean, that's my worst take-home message. I mean, all right, so what that tells me is that it's no longer second-line therapy, it's no longer dotted lines in the guidelines, right? It's at least an equal discussion if you're going to be fair to patients. There are potential benefits, like you said, hospitalizations and mortality, and my experience is the same as yours. They want to know how they're going to feel. So I'm really looking forward to your quality of life paper. I know you're working on that. I think that would be wonderful to hear that. And the only caution I have for anyone listening who hadn't seen your presentation, the only group I'm still a little concerned about, I know you're going to delve into it, is the over 75 crowd. Right. I mean, I think that's still to be looked at.
You know, Eric, there were 3 or 4 groups that we're concerned about. One is the patients who are under the age of 75. They do very well. Their entire 95% confidence interval slides in the direction of ablation. It's the ones that are over the age of 75. Now, that doesn't mean that you can't ablate them if you're doing it for the purposes of quality of life.
Right.
But they may be just fine on a drug.
Yeah, and I think you're going to probably give us more information on it as time goes on, right?
Right.
Yeah.
And patients who had class 2 or 3 heart failure, cardiomyopathies, minorities, all did better.
Yeah, that was really impressive.
On the ablation side. Now, Eric, we're not trying to say that this is a perfect trial. There are components that are neutral, depending on how the analysis is done. We're not selling ablation catheters. I went into this trial with equipoise, and I went into this trial saying, I don't really care how it turns out, but I think you do have the prerogative to look at the statistics and see where they lead you.
Right.
And so I think that will ablations go up or down? I don't know.
I don't think that matters either, you know? I totally agree with you. The bottom line is we have finally a trial that's really looked at this in detail. I think it's up to the community to take a close look at the paper when it comes out and to make informed decisions for their patients, because if a patient comes and says, I'm only doing this because I want to stop anticoagulants, as you perfectly pointed out, that's not the trial. So I think that the key is that people need to read the trial, need to look at all the results. And in particular, I'm looking forward to, I know you're probably working on a gazillion papers as always, but I think they're going to be very important, and especially quality of life.
Right.
I'm waiting for that one. But Doug?
September.
I wish we had more time. Maybe we'll do a follow-up, do our 3rd segment of this after some of the newer data come out. Thanks again for being here, and thanks an awful lot for doing this trial.
Thank you, Eric.
My pleasure.